So good evening, everyone. And this evening we'll be concluding our tutorial on acute and chronic pain. And we've done a lot about acute pain, the definition, pathophysiology, the pain pathway, and the pain mediators. We've looked at different pain assessment scale and tools. Today we'll be looking at chronic pain, as it were. All right, a lot of times, most anesthetists deal with acute pain, post-op pain, but chronic pain is also a part of our practice. And the establishment of pain clinic actually is based on management of chronic pain. So today we'll look at chronic pain. And all right, by definition, the International Society of Study for Pain, all right, had different definitions, and we're going to just summarize them as a pain that is constant or intermittent, persisting beyond the expected healing time. So when there's an injury or there's a trauma or surgical injury, there's an expected time for that injury to heal and the pain to resolve with management. But when pain becomes constant or off and on, persisting beyond the expected healing time, it refers to chronic pain. Also, it is not usually associated with a specific cause or injury type, okay, and lasts, some people say 3 to 6 months. The ICD-11 classifies chronic pain into 2 primary and secondary pain syndromes. So the American Society of Anesthesiologists now put all of this together and defines chronic pain as pain that extends beyond the expected temporary boundary of tissue injury and normal healing and adversely affect the function and well-being of the individual. So this encapsulates what chronic pain is all about. Number one is a pain that extends beyond the expected healing period, all right? And it's a pain that adversely affects the activities of daily living of the individual. Okay, so epidemiology, about 20 to 30% of adults suffer from chronic pain globally. All right, it's common in post-surgical patients, cancer survivors, and ICU survivors, and is part of the element of what we know as post-ICU syndrome. Also, chronic pain impacts perioperative outcomes, can prolong stay in the ICU, can lead to difficulty weaning from ventilator, and because of the need to treat it, it also increases the risk of opioid dependence. Like somebody once said, all right, if pain is only looked at in terms of its intensity, it's likened to, assessing music due to its loudness. So pain is not just about the intensity, all right? It affects every aspect of the patient's function and well-being. And the pathophysiology, there are different pathophysiology. Number one is the peripheral sensitization, all right? This is due to increased responsiveness of the nociceptors due to inflammatory mediators. We looked at this last time when we were talking about pain, acute pain. Also, increased excitability of the dorsal horn neurons, especially at the spinal cord level. Okay, this can lead to sensation of pain in the absence of any cause. Okay, neuroplasticity, this is important, all right, as changes in the patient's central nervous system can lead to pain memory, all right, and this will lead to some behavioral changes as we're going to be looking at it. Then pain also has psychological and social components. And this what makes chronic pain unique in itself because it demands the pain, chronic pain should be treated holistically, not just looking at the intensity and alleviating symptoms. So chronic pain can lead to anxiety, depression, catastrophizing, which we're going to look at, okay, as we go on. The key neurochemical changes in acute pain is increased glutamate and NMDA receptor activity will reduce GABAergic inhibition and microglia activation. Okay. All right. So there are different types of chronic pain. Different people define it different way, but I like this. All right. Some people have even classified as malignant, non-malignant, and pain syndrome. But looking at it from this way, we have 4 different types. The nociceptive pain, all right, neuropathic. Neuropathic is actually due to peripheral neuropathy, like you see in your diabetic patient. Post-hepatic neuralgia, okay. Mixed pain, this could be from cancer pain or chronic low back pain. We have what we know as the chronic pain syndromes, including the central pain syndromes and fibromyalgia. And we're going to look at some of these chronic pain syndromes in the course of this tutorial. Okay. All right. So like acute pain, we talked about it last week. Chronic pain needs also to be assessed, but there are different components, okay? We look at the history, okay? This is what will categorize the pain as chronic, lasting more than 3 to 6 months after the initial injury, okay? We look at the character, aggravating or relieving factors, okay? We'll have the tools or scales, okay? Most of the time we use the brief pain inventory and the McGee pain questionnaire. We looked at these pain scales last time in our discussion. Then very important aspect of chronic pain assessment is the functional assessment. All right, how does the chronic pain affect sleep, mobility, and the psychological well-being of the individual? All right, functional assessment also will include and involve screening for risk of opioid-induced hyperalgesia and other side effects or adverse effects of opioid, and also looking at the mental health disorders that's associated with chronic pain. In actual sense, most patients that suffer from chronic pain, all right, do so not just from the nociceptive angle, but from the functional aspect affecting every aspect of their being. Okay, so we have the chronic pain syndromes. There are different types. So the number one is the neuropathic pain syndromes. All right, as the name suggests, these are pains that are caused by either damage or dysfunction of the nervous system. Neuropathic pain syndromes. All right, they all have one thing in common, either pain that is induced either by damage or dysfunction of the nervous system. So there are different types. We have the post-hepatic neuralgia. All right, this is pain after episostal infection, which affects the nerves. We have the diabetic peripheral neuropathy, all right, which affects is a symmetrical distal polyneuropathy in diabetic patient. We have the trigeminal neuralgia, all right, which is a unilateral face pain along the distribution of the trigeminal nerve. Then we have the phantom limb pain when I remember, I think 2 weeks ago, somebody was asking about this question. When a limb has been amputated, but the patient still feel pains in that part of the limb that has been amputated. So it's phantom limb pain. These all has to do with either damage or dysfunction of the nervous system. The key features of neuropathic pain syndromes include, but not limited to, burning. It's a burning sensation. Sometimes it can come like an electric wave shock, all right, allodynia or hypergeusia, all right. So there are different lines of management for this group of pain, all right. The first line, you want to use the gabapentin, pregabalin group, all right, and you want to add the tricyclic antidepressants, amitriptyline. All right, we're going to see some of these medications as we go on. Second line is the serotonin, norepinephrine, reuptake inhibitors. All right, the duloxetine, and you can even have the complex or mixed opioid, the tramadol. All right, topicals you can have lidocaine, 5% patch, or capsaicin. But most importantly is that in all of these types of neuropathic pain syndrome, it's a damage or dysfunction of the nerves or the nervous system. The second aspect of chronic pain syndrome is the musculoskeletal pain syndromes. All right. So examples are the osteoarthritis, all right, which ensue from chronic degenerative joint pain. All right. We have low back pain, which can be nociceptive, neuropathic, or mixed. Then we have the myofascial pain syndrome. All right. This, result from trigger points in different muscle groups, causing referred pain. Okay, so the management of this is a little different. All right, most of these musculoskeletal pain syndromes will respond to your non-steroids, all right, and paracetamol. Physical exercise, physical therapy also will help. All right, for those patients who have neuropathic component of the chronic pain, you may want to use the gabapentinoids, the uh, gabapentin and the pregabalin. Yeah, so I decided to go a little further on this because this is common. Fibromyalgia, all right, is one of the chronic pain syndromes and it's important. So I'm spending some time to discuss this. Okay, so fibromyalgia is a chronic widespread pain syndrome characterized by diffuse musculoskeletal pain, associated fatigue, sleep disturbances, and cognitive symptoms like what we know the fibro fog, okay, without evidence of any inflammatory or structural disorder. This is what marks fibromyalgia, all right? It's a chronic widespread pain syndrome, all right, characterized by diffuse musculoskeletal pain, fatigue, sleep disorders, and cognitive symptoms. All right, the trick here is that there's no evidence of inflammatory or structural disorder causing these widespread pain symptoms or the syndromes. All right, it's common among female rather, with a female to male ratio of 9:1, okay, affecting about 2 to 4% of global population, and it's common among 30 to 50 years old, okay. Now, the clinical feature is that one, there's widespread pain, all right, it's on both sides, and it can be above and below the waist or even affect the axial skeleton, and this occurring more than 3 months. All right, traditionally, there are about 11 of 18 points, all right, the trigger points, especially the trapezius, the lateral epicondyle, and the gluteal region. There are associated symptoms, all right, fatigue, non-restorative sleep, all right, cognitive dysfunction, all right, loss of personality, all right, inability to recall or remember stuff, and it's known as the fibro fog, like a fog covering the brain and the central nervous system. All right, this also will lead to anxiety, depression, all right, and headaches and paresthesia. All right, so we have one of the common things about fibromyalgia is that they are commonly associated with what we know as IBS, the irritable bowel syndrome. All right, so these are patients that suffer a lot, and is one of the common chronic pain syndromes we have. So we have the diagnostic criteria, all right, that was first brought out in 2010, reversed in 2016. All right, so we have the WPI, should be more than 7, all right, and the symptom severity should be more than 5. Okay, so the WPI is known as the widespread pain index. How many places? All right, if the patient is suffering pain, should have more than 7. Okay, and the symptom severity should be greater than 5. All right, number 2, the symptoms should be present for more than 3 months, and there is no other disorder explaining the pain. So this is the diagnostic, criteria for fibromyalgia. So we have both pharmacological and non-pharmacological methods of managing fibromyalgia. All right. The first line is non-pharmacological, which has to do with education. All right. The patient needs to understand what he or she is going through, explaining chronic pain mechanisms, exercise. All right. This has to do with low part aerobic exercise, stretching, okay, cognitive behavioral therapy, and sleep hygiene. This is very crucial in managing patients with fibromyalgia. Pharmacological, the serotonin norepinephrine reuptake inhibitors, the duloxetine, the milnacipran are agents that can be used. Anticonvulsants and your gabapentinoids, your gabapentin, pregabalin. All right, TCA is tricyclic antidepressants, and your non-steroidal can be used, but it's important that patient's case should be individualized so that the therapy that works for the patient is what should be administered. Okay, so for those of you like mnemonics like me, all right, remember the fibromyalgia can be remembered by fibro pain, all right, fibro pain. Okay, number 1, fatigue, patient is chronically tired, all right. There's insomnia, no restorative sleep, patient finds it difficult to sleep. Then we have the bowel syndromes, the inflammatory irritable bowel syndrome, restless leg with mood disturbance. Then we have overall pain in more than 5 to 7 regions of the body. Then patient has psychological symptoms, is either anxious or depressed, allodynia, pain from non-painful stimuli, all right, increased sensitivity, okay, and neck and shoulder stiffness. These are common tender points, especially affecting the trapezius muscle. All right, so fibro pain will help you remember the 9 components of fibromyalgia. Then we have the complex regional pain syndromes. These are chronic pain. Are you there? I hope I'm not boring you. They look like boring syndrome. Are you following me?
Yes, sir. Yes, sir.
Okay. You're not bored.
Yes, Professor. Yes, Prof.
Okay. So we have the complex regional pain syndrome. All right. This is a chronic pain condition that is characterized by persistent severe pain, usually following trauma or surgery. And this pain is out of proportion to the initial injury. Now, why this is important is because this readily can affect our post-op patient. All right. After surgery, after discharge, they have pain that seems to be persistent. And when you look at the surgical site and the tissue damage, whatever it is out of proportion. All right. In terms of the inciting injury. All right. So complex regional pain syndrome also involves autonomic, all right, with blood pressure changes, heart rate, all right, sensory and motor disturbances. So there are two types of complex regional pain syndrome. The CRPS1 is a reflex sympathetic dystrophy, all right? In this syndrome, there's no confirmed nerve injury and usually follows minor trauma or surgery, all right? In the CRPS type 2, the contagia there's confirmed nerve injury, all right? Now note that the nerve injury, all right, may not be the first symptom. There could be trauma or surgery, but due to central sensitization and all those chronic inflammatory processes, there could be some neuropathy, all right? And that's why this is distinguished. And the reason why we need to know the two types is the management modalities also will depend on the type of chronic, complex regional pain syndrome you have. So the features, there's severe burning pain, like I mentioned, out of proportion to the injury, all right? Pain from non-painful stimuli, all right? Hyperalgesia, exaggerated response to painful stimuli, color changes, temperature asymmetry, feeling hot on one part of the body and feeling cold on the other, all right? Due to the pain, lack of movement, you can have motor atrophic changes. Muscle atrophy may ensue with joint stiffness, hair and nail growth changes. Okay, so the Budapest diagnostic criteria is used to make a diagnosis of CRPS. Okay, so for a patient to end a diagnosis of complex regional pain syndrome, the patient must have a pain that is persistent, one, and is disproportionate to an inciting event. Okay, number two is that at least it must have one symptom in 3 of the 4 categories. All right. So in sensory, the patient may have apaesthesia or allodynia. All right. In vasomotor category, the patient may have temperature asymmetry or color changes. In pseudomotor, all right, there could be edema or sweating, and motor atrophy, decreased range of movement, and you can have some muscle wasting and all that. So the Budapest diagnostic criteria ensures that you make the right diagnosis of CRPS. Management, all right, there are two types. We have pharmacological and interventional or invasive management. Early on, you want to start the patients on non-steroidal, okay? Then you want to use your gabapentinoids, all right? Corticosteroids could usually help, especially in early CRPS, okay? Biphosphonates, especially dronates, also can be called to action in this patient. Then the interventional sympathetic nerve block or spinal cord stimulation, all right? This has to do with stimulating the dorsal horn of the spinal cord, which helps to reduce pain sensitization, and it also helps, and this helps with closing the gate, all right, in the substantia gelatinosa. If you remember lamina 2 of what we talked about initially. Non-pharmacological therapy like physical therapy, desensitization, and mobilization come to play. Some of these non-pharmacological therapy, we will look at them as we go on. Like I mentioned, so pain shouldn't be assessed based on intensity alone. All right, if we assess pain based on intensity alone, like I said, it's like we're assessing music based on how loud it is. Okay, so chronic pain, all right, can be considered a driving force. What it does is that it carves cortical anatomy and physiology. All right, so all of these cause a dysfunction in the brain. All right, with a chronic pain brain. All right, and MRI has shown some specific uh, changes in the brain of chronic pain sufferers. All right, and this instills a mindset of pain. I'm always in pain. The patient is always complaining in pain, any little activity in pain, because there's a increased repeated sensitization has created an abnormal marking or coughing in the cortical parts of the brain. So chronic pain has a psychosocial phenomena in which biological and psychological and social factors dynamically interact with one another. And this is why chronic pain should be a subspecialty, management of chronic pain, because of all this involvement. Okay, and all of this will result in depression, mood fluctuations, anxiety, altered perceptions, all right, impaired cognition and emotional instability, all right. And this does not only affect the patient, it affects relatives, caregivers, everybody around them. So it's a whole lot of web that brings many different people into its suffering range. Okay, another thing we need to look at pain is the stress response. Okay, when a patient is been in chronic persistent pain, there's a prolongation of the stress response to pain. All right, so the patient become tachycardic with a flight or fight response, with exaggerated release of your norepinephrine and epinephrine. Over time, this can impact brain function, resulting in changes in behavior. All right. In addition, the stress response can also lead to heart conditions, gastrointestinal changes, and what have you. All right. So sometimes patients with chronic pain, all right, who did not have primary cardiac problems could develop cardiac problems because of increased impact of the stress response on the heart. Okay, so increased response, stress response, all right, could be another very important consideration in managing chronic pain. All right, chronic pain and mental health, we mentioned this before. All right, like I said, MRI of chronic pain sufferers have shown some chemical and physical changes in the brain. All right, and this can affect the mental health of this patient. All right, pain is also linked to emotions, if you remember the definition of pain. All right, and in fact, all of this will be, lead to circuitry of the nervous system with the common brainstem commonly involved. So we've talked about this, all right? Sometimes the early sensitive symptom of depression are pain disorders, all right? When a patient complains of pain morning, night, every day, depression most likely will set in. So pain disorders could be an early signs of depression, especially now that we have a lot of people who are depressed who are pushed to committing suicide. All right. Sometimes when we can effectively manage the chronic pain syndrome, we may reduce the impact of depression and consequently the risk of suicide, especially even among healthcare workers. All right. So it's been known that patients with more severe depression and anxiety symptoms also have an increase of pain problems. So it's not just enough to just look at depression. We must look at underlying pain syndromes that even the patient may not be fully cognizant of as leading to or linked to the depressive symptoms that he or she is exhibiting. In fact, in a detailed meta-analysis, the frequency of reporting pain complaints by patients with depression, all right, almost range between 15 to 100 with a mean value of 65%. And that's alarmingly high, all right? Patients who complain of pain, who are seen at mental health clinic, all right? Or patients who are in mental health clinic, most of them, more than half of them, report having or suffering from some chronic pain disorders. Okay, and this is also very crucial, all right? Awareness of the body, okay? And pain behavior. We're going to see some of this, okay? Let's just go to this one, all right? Cognition, pain awareness. Okay, let's do this, okay? So activation of complex brain systems as a result of chronic pain may increase awareness of pain with decreased pain tolerance, okay? And this can signal the fight or flight system with heightened sensitivity to other threat cues, all right? Things that normally will not cause pain. The patient becomes aware, I'm going to have pain. If I do this, I'm going to have pain, okay? A patient may also learn to assume a body position, all right, like limping, for instance, or like sitting on one side of their body to avoid certain movements which may amplify or intensify the pain. And all of this can lead to a sort of problems like, deformities for all your care. And these are just results of chronic pain that the patient is going through. Now we have cognition. All right, chronic pain negatively can affect the cognitive ability. Okay, now we have these three different, syndromes, or should I call, beliefs. We have what you know as the catastrophizing. All right, when the chronic pain sufferers misinterprets an event as a catastrophe. All right, the patient hits his toe, against an object. And the next thing he will say is that this pain will ruin his life. All right. So an ordinary pain is being seen as a catastrophe. This pain is going to ruin my life. It's going to kill me. All right. This is catastrophizing. All right. And this is common among chronic pain syndromes. I hope that by bringing this to our attention, we'll be able to be more attentive as we care for our patient, henceforth listening to them. All right. Some of these things may give a cue to what they are going through in terms of chronic pain syndromes. Personalization, all right? This is when a patient takes personal responsibility for negative events in his or her life. All right, for instance, especially diabetic patient, I'm in so much pain because I didn't take enough care of myself. It's my fault. If I had taken my insulin, if I had listened to my doctors, if I had changed my diet, all right. So taking personal responsibility for negative event, that's personalization. All right. There's what they call selective abstraction. All right. When the patient selectively attend to the negative aspect of a situation. All right. Like we say, count your blessing. But this one says no, because I couldn't complete this exercise, so I'm a failure. All right. Selective abstraction can also occur in different aspects. All right. We heard about the unfortunate incident of a medical student in Nigeria who failed MB, I think part 1 or part 2, who committed suicide. What led him to commit suicide? I failed the exam, so I'm a failure. But some of us have failed many times before. All right. And we have risen. So selective abstraction could be a sign of chronic pain, abnormal cognition. So let's go home to treating or managing chronic pain. Note that the goals of managing chronic pain is to improve the pain. All right, the pain that the patient suffers is not to cure the pain, and this is important. All right, we're going to improve pain score. Patient who comes to you with a pain score of maybe 7/10, all right, with your therapy, you want to reduce that pain score to maybe less than 4, all right? Then you want to decrease the intensity and the suffering that the patient undergoes. A patient with fibromyalgia who cannot sleep, all right, with your therapy should improve the sleep pattern and improve activities of daily living. All right. Patient likes to play tennis, likes to take a walk, but because of the chronic pain, he's not been able to do it. But once you start therapy, that should improve. All right. These are the 3 goals of chronic pain management. All right. So principles of management, we'll need to look at the WHO analgesic ladder. All right. I hope you know that we have the one for acute pain and the one for chronic pain. Okay, so the slide on the part of the slide on the right shows us the analgesic, the WHO analgesic ladder. All right, for chronic pain, okay, you want to start from step 1 to step 4, while from acute pain you want to start from step 4 and taper it down to step 1. So for step 1 of chronic pain, you want to start with non-opioids, okay? Then you gradually increase to step 2, weak opioids, step 3, and step 4. All right, so there's an increasing ladder in the management of chronic pain. Okay, you don't want to start with step 3 or step 4. That is for chronic pain. For acute pain. When acute pain begins to resolve, you want to come down from strong opioids to non-opioid. But for chronic pain, you start and go stepwise. Okay, so this is the WHO analgesic ladder for the management of chronic pain. All right, so apart from analgesics and non-steroidal opioids and what have you, we have adjuvants, and this is important. Adjuvants helps, especially when it has to do with neuropathic pain. It also helps with improving activities of daily living. So we have the antidepressants, the serotonin, norepinephrine reuptake inhibitors. We have the tricyclic antidepressants. We have the anticonvulsants and the gabapentinoids. Muscle relaxants, sometimes when you're especially those with musculofacial or myofascial pain, okay, topical agents and your NMD antagonists. In fact, there was a time in some centers we have what they call ketamine clinic, okay, ketamine clinic, and this is usually for patients who have refractory pain, all right, or having chronic pain syndrome. Ketamine, all right, can be used for such patients. So non-pharmacological, all right, we have graded exercise programs, all right, to prevent or limit joint stiffness, muscle atrophy. This should be graded, okay? Superficial heating methods, ankle puncture, all right? And we have the transcutaneous electrical nerve stimulators. We have ice baths, massage, and yoga, okay? Then we have the psychological method. This is very crucial. Psychological methods in the management of chronic pain, all right? Cognitive therapy, for instance, all right? Now, this is based on the attitude of the patient to pain, all right? Sometimes those of you that go to gym, you hear no pain, no gain, all right? When you have, I'm going through this just because there's a good purpose out of it. So the experience of the pain does not connote a negative impact on the patient. The patient is sweating, is in pain, but he knows that I'm getting a good result from it, all right? So this is cognitive therapy, all right? And a lot of times it also has to do with distraction and attention diversion. What it means is that, when the pain is coming, do something else, all right? Um, Watch movie or take a walk, all right? So these are cognitive therapy. And a lot of times the patient may be able to come to a point where he's able to tell you that once I'm about to feel the pain or I'm feeling the pain, I just do something. Go on TikTok, for instance, or visit a friend. All right, these are distraction or coping strategies that different chronic pain sufferers adopt to reduce their pain suffering. Then we have the biofeedback technique, all right? This provides feedback to the patient. And the important thing is this, the patient, once we have different types, we have the central and the peripheral biofeedback. Okay, you put sensors in the patient's brain and you provide feedback. When you're feeling pain, look at what happens to your muscle activity, what happens to your heart rate. Your brain waves increase when you do this. But if you are able to adopt some relaxation technique or you're able to divert it, you see that the heart rate comes down, becomes normalized. With this positive feedback, the patient is able to adapt, all right, to control, all right, his own or her own response to the painful stimuli. So this is what we know as the biofeedback technique. Then we have the operant or the behavior technique as part of the psychological method, all right? So this is based on the fact that the behavior of a patient with chronic pain is determined by the consequences of the behavior. So we have what we call the positive reinforcers and the what's it called, the withdrawal of reinforcers. What does this mean? Okay, when positive reinforcers, when you pay attention to the pain, when you are just taking medications and you avoiding your normal duties, this will aggravate pain behaviors. For instance, a patient says, I can't go to work, I can't stand the pain, it's too much. All right, this will aggravate the pain. Okay, so this is, we are saying that because of this behavior, you're having more pain. So why don't you withdraw the reinforcers or apply negative consequences that reduce maladaptive pain behavior? All right, somebody said, don't give up, show up, wake up in the morning, do your exercise. Okay, you are withdrawing the reinforcers that amplify the pain. Okay, so it involves introducing behavioral exercises that help to reduce pain behaviors. Okay, increase healthy behaviors. Okay, and encourage reduction in medication. Don't some people, including me, once I'm having slight pain, I'm going for NSAID straight. I don't like pain because it disturbs me. But you need to also realize that those behaviors are pain reinforcers, okay? And we need to reduce, we need to encourage the patient, all right, to reduce the amount of medication it takes. Then we have the group therapy, all right, where a group of people, especially people with fibromyalgia or complex regional pain syndromes, can have a group. All right, it helps in managing chronic pain. So they can have coping skills training groups together. All right, they play a draft, they play snookers, they, social support groups, they have different times that they go out together and support one another. All right, we have invasive techniques, the somatic nerve blocks, sympathetic nerve blocks, and all of that. So I think we've come to the end of chronic pain. I just wrote, for instance, the spinal cord stimulation, like I mentioned, or the dorsal column stimulation, is when you stimulate the large A fibers producing analgesia, all right, and it kind of activates the descending modulatory systems and inhibition of sympathetic flow. We can have intracerebral stimulation when you put some stimulation to the brain, and usually reserved for intractable cancer pain, okay, but rarely used for neuropathic pain or patients with non-malignant pain. All right, let me stop here. It's been a long day, and if you have any questions, any queries, we may be able to take them now. Let me stop